Somatization, when patients don't improve. It's always difficult when patients don't improve. The tendency is to assume this is due to something you didn't do or patient noncompliance. But is it possible other factors influence the probability of improvement? It has been known for some time that psychosocial factors influence who recovers and how quickly they recover. A new study looks at one of those factors. The title is Somatization is associated with worse outcome in a chiropractic patient population with neck pain and low back pain, published in Manual Therapy in 2015. So the obvious question is, what is somatization, also pronounced somatization? It's defined as an unconscious psychological process that expresses psychological distress as physical symptoms. The problem occurs when similar and overlapping names are used. The first distinction is then a process versus a disorder. As a disorder, somatization disorder or somatoform disorder is a psychiatric condition marked by multiple medically unexplained physical or somatic symptoms. Regardless of whether it is a process or disorder, presenting symptoms that often occur are fatigue, sleep disturbance, multiple GI or sexual dysfunction complaints, and nonspecific musculoskeletal complaints. The other confusion is that different groups define somatoform disorders differently. For the World Health Organization, it's defined as repeated presentation of physical symptoms together with persistent requests for medical investigations in spite of repeated negative findings and reassurances by doctors that the symptoms have no physical basis. And for the DSM-4, 4 criteria must be met. The individual must report a history of pain affecting at least 4 different parts or functions of the body, a history of at least 2 gastrointestinal symptoms, a history of at least 1 sexual or reproductive symptom, and 1 symptom must mimic a neurological condition. Then in the latest version of the DSM-5, it was combined with undifferentiated somatoform disorder to become somatic symptom disorder, with 2 types, one predominantly somatic complaints and the other predominantly pain complaints. It no longer requires a specific number of somatic symptoms. And the ICD-10 still includes somatization syndrome. Between 0.2 and 2% of women and less than 0.2% of men suffer from somatization disorder in the U.S. The patient is not feigning symptoms. This would be fictitious disorder or malingering. Patients who somatize are more likely to have a mood disorder such as depression or anxiety. In other words, somatic symptoms accompanying other disorders. So why does somatization occur? Well, basically, there are 3 theories. It might represent the mind's attempt at avoiding recognition of depression and so therefore used as a defense against psychological distress. It may be that it's the result of heightened sensitivity to physical sensations, or it may be the result of catastrophic thinking about physical sensations. So let's move into the study. Who were the patients? Participants were recruited by 97 chiropractors in their clinics in Belgium and the Netherlands. Chiropractors were asked to recruit 15 patients each for this study. Participants who had not been treated by a chiropractor within the prior 6 months were eligible. They were between 18 and 64 years old with neck and or low back pain with or without radiation to an extremity as their chief complaint. Specifically, 87% reported a previous episode of the same complaint. Almost half were chronic at the time of treatment, greater than 3 months, and about 1/3 had radiating complaints into the extremities. The exclusion criteria were the typical: tumor, fracture, infection, or any condition that might be a contraindication to spinal manipulative therapy. Outcome measures were determined by self-administered patient questionnaires that were sent at baseline, at the end of the second visit, and at 1, 3, 6, and 12 months. Most patients completed these online. In addition to demographics and baseline pain, outcomes included social and psychological factors, including distress, depression, anxiety, and somatization. The patient's beliefs with regard to the effect of physical activity and work on their spinal complaint, and their degree of social support. There were a total of 917 patients. 35.6% presented with neck pain and 64.4% presented with low back pain. So let's review the results. Lower scores on somatization were consistently associated with perceived improved recovery, functional status, and pain for both neck pain and low back pain. Depression was associated with function in low back pain patients. So what does this mean? Well, a person with neck pain with a mildly elevated score of 1 for somatization is 1.55 times more likely to report that he or she has not recovered. A person with a strongly elevated score of 2 on somatization is 2.4 times more likely than a person who does not somatize to report that he or she is not recovered. The researchers did not find any association between recovery with any of the other 3 outcome measures: distress, anxiety, and social support. Patients in general chiropractic practice do not present with complicated psychological profiles. Less than 1% scored the highest score on all subdomains of the measurement tool for social and psychological factors. So let's discuss time. The relationship to somatization and recovery was not consistent across time. All patients tended to improve the most by 6 months. Look at the results for neck pain patients. You can see that patients on average gradually improved with a slight decline at 12 months. You can see the same for low back pain patients. So limitations are what we don't know. We don't know what percentages of patients with or without radiation into the extremities improved. And because these were patients recruited from chiropractors in 2 countries and no treatment protocol was standardized, we don't know what types of treatment were used other than SMT, or how often patients were seen, or when and if patients stopped care. The interest in screening patients for psychosocial factors is not new. It became most apparent around 2012 with the international interest in what is called the START approach. START stands for Subgroups for Targeted Treatment. It was an attempt to answer the evidence-based question. Given recent research, it seems consistent in the observation that prognosis is more based on psychosocial factors that include fear about pain, mood, work satisfaction, etc. Should these be part of screening and categorizing of patients so that providers could initiate psychosocial strategies early in the management of this group of patients? The START back screening tool begins with item 1. Overall, how bothersome has your back pain been in the last 2 weeks? Then a focus on psychosocial subscale items. It's really not safe for a person with a condition like mine to be physically active. Worrying thoughts have been going through my mind a lot of the time over the last 2 weeks. I feel that my back pain is terrible and that it is never going to get any better. In general, in the last 2 weeks, I have not enjoyed all the things I used to enjoy. The effectiveness of using this strategy for prediction and management is highly variable based on practitioner and context. A more simple approach might be screening for depression, which is often associated with somatization. The standard is to use 9 items which represent the clinical criteria for major depression in the DSM. The first 2, feeling blue and anhedonia, must be present, and at least 3 others to total 5 items present out of the 9. Feeling blue and anhedonia are actually part of a screen called the Prime MD2. These are very sensitive for screening major depression. Anhedonia is similar to item 9 of the START questionnaire, asking about enjoyment of things in life that used to bring pleasure. Now the next step is to look for the other 3 items, which are divided into physical and psychological symptoms and signs, or to use a more detailed scoring system using the Patient Health Questionnaire 9. The Patient Health Questionnaire 9 utilizes the DSM-4 criteria with one additional question regarding the effect of these symptoms on work, home environment, or getting along with people. This is available online for automatic scoring. The patient is asked, over the last 2 weeks, for each of the 9 items. The patient rates by choosing not at all, a few days, half of days, and nearly every day. Let's put this together into an algorithmic approach. Statistically, we can see that the prevalence for major depression is between 7 and 12%. If we get negative responses on the 2-question screen, the likelihood of depression is only 1%. If we get positives on the 2-question screen, we then look to the PHQ-9. If the score is above or equal to 10, the likelihood of depression is between 49 and 59%. If the score is below 10, the likelihood of depression drops dramatically to 1 to 4%. So here we can see the approach. Screen patients with a history of chronic illness or pain, or in patients with unexplained musculoskeletal complaints. You use the PRIME-MD2 questionnaire as the screen. For those with a positive response, you move on to the PHQ-9. If the score is less than 10, you monitor. If the score is greater than 10, search for other clues for secondary depression, including other disorders and medications. Refer the patient to their PCP or a psychologist. For somatization, management includes cognitive behavioral therapy, which focuses on getting patients to realize their ailments are not catastrophic, and attempts to enable them to gradually return to being active without fear of worsening their symptoms. There is some evidence that consultation and collaboration with primary care physicians has demonstrated some effectiveness, so our support as chiropractors is likely to also be beneficial. So we wouldn't want to use this approach for all neck and low back pain patients, but for those who we suspect may have more going on because of unusual symptoms or a cluster of fatigue, sleep disturbance, multiple GI or sexual dysfunction complaints, and multiple nonspecific musculoskeletal complaints, in addition to their spinal pain, screening for depression and referral for adjunctive management may be a reasonable approach.